So I'm a junior doctor in one of the health boards in Wales, and I'll be presenting this case of pulmonary embolism and one of the complications of treatment in one patient we saw. I know we've heard a lot of information already today about VTE, so I won't bore us with all of this, but just to refresh, VTE encompasses pulmonary embolism and DVT, and we're very familiar with this term because most often when we have patients who come into hospital, we need to put them on VTE prophylaxis to prevent clot formation on admission. And it's seen as the third most common cardiovascular disease after myocardial infarction and stroke. And we know what happens in PE is that there's a thrombus, which usually forms in the veins and mostly in the veins of the lower limbs. This then dislodges and goes to obstruct the pulmonary system, causing some severe dysfunction. And it does cause a lot of morbidity and mortality. So this patient I'll be presenting was a 32-year-old obese lady who came in with fever, pain, and swelling in her right thigh. She then described some chest pain she had, which sounded pleuritic from the description, and she was quite short of breath. She had no significant past medical history. She wasn't on any routine medications. From her social history, she was smoking 40 sticks of cigarette a day, and she's been smoking for over 20 years. And she also uses quite a number of IV drugs, from heroin to cocaine. And of course, when we saw this, it was ringing a lot of bells of thrombosis everywhere. So we went on and examined this lady. She was tachycardic at 114. She was pyrexia, and she was saturating at 78% in room air. The chest examination revealed reduced breath sounds bilaterally. And on the right thigh, there was this really big abscess with surrounding erythema. The rest of the system examination was fine. At this point, we sent for some investigations, both imaging and bloods. We did a full blood count. This showed pancytopenia, and the CRP was elevated at 314. The UNEs and LFTs were normal. Our D-dimers were over 20,000. Our blood culture was positive for MRSA. We did a blood gas, and she was in type 1 respiratory failure. And of course, we went on to request the first-line imaging for suspected pulmonary embolism, which is the CT pulmonary angio. And this then revealed a right-sided pulmonary embolism with basal atelectasis. And at this point, of course, we made an assessment of type 1 respiratory failure, secondary to the pulmonary embolism. She had this right thigh abscess, which at this point must have then caused some septicemia already with the MRSA, and then may have led to the pancytopenia. And of course, there was some element of pneumonia. COVID being at the center of everything in the last 1 year, we thought the blood picture may have been a result of vaccine, but we then subsequently dismissed this because she hadn't taken any of the vaccines yet. And going on to manage this patient, she definitely needed some oxygen because she was saturating at 78. And even on commencing oxygen, she was still saturating at less than 19% on 10 liters. So we got in the HDU team to come and review. And after review, they deemed that fit for intubation and mechanical ventilation. And so she was then transferred to the ITU. We gave her some IV fluids. She was on antibiotics because of the sepsis. We had to drain the abscess and dress with some antibiotics and give some blood transfusion. Now, the first line for managing VT now we know is DOAC. And in this patient, we couldn't go ahead with that because at some point she was on rifampicin, which is an enzyme inducer, and the hematologist advised it would not be the best option, either the DOAC or the warfarin. And so the best would be to start her on some enoxaparin, which we did. And then she was in the HTU for about a week, and subsequently she was out of type 1 respiratory failure and stepped down to the ward. But then she had a complication of our treatment. She had a massive hemorrhage. So I'll just quickly run through the progress of this patient. She was in the HTU, like I mentioned, for 1 week and then stepped down to the ward. And then a few days after that, there was a med call put out for cardiac arrest on the ward she was on. And we went in there and it was a massive hemorrhage everywhere. The ITU team came in. She had to be intubated again and taken back to the ITU. She had blood transfusion with both Pacra cells and fresh frozen plasma. So she was in the HDU again a second time, and subsequently she was stepped down to the ward again. And since we're considering discharging her, she had to be educated on what she had, which was the pulmonary embolism. So these risk factors that may have put her at a risk of developing this pulmonary embolism, which would include the smoking and the her weight. And so she was educated on this. And because she needed to go home and Clexin, she was also educated on how to self-administer the anticoagulant, and also to be followed up by the hematology team and the drug and alcohol service. And the reason for the follow-up with hematology is for a likelihood of conversion to DOAC at some point after having Clexin for a while. So this has been spoken about today by the consultants who have spoken earlier, the focus triad, which kind of gives an idea of some of the mechanisms that work together to put people at an increased risk of thromboembolism. And in this patient, she had quite a number of risk factors for pulmonary embolism. And right from the symptoms she presented with, pulmonary embolism was very high on the list. She was obese, one with obesity has been described as a chronic inflammatory condition with release of some procoagulants, and that will cause some hypercoagulability of blood. With IV drug abuse, that causes some endothelial damage. And with smoking too, smoking has been seen also to damage endothelial lining, and at the same time, change the surface of platelets, making them clump together. So in this patient, she had quite a number of risk factors for PE. So in summary, I have described pulmonary embolism in a young patient who had quite a number of risk factors, and pulmonary embolism on its own causes severe respiratory dysfunction and can have complications both from the disease itself and from the treatment, just as we have seen in this patient. So understanding the risk factors for possible pulmonary embolism can aid in prevention as well as making appropriate diagnosis in order to treat the patient. Thank you for listening.
Thank you very much. It's a common clinical dilemma that we have, you know, somebody with a blood clot who also at high risk of bleeding or has had an acute bleed. And certainly that's the kind of thing that I get called about very frequently in attending weeks. What was the eventual diagnosis in terms of the reason for the abscess? Was that felt to be related to her use of intravenous drugs, or was there an underlying unifying diagnosis for that and the pancytopenia?
So it was more of the injection, because apparently she had been ill for over 5 days before presenting to the hospital, but that didn't stop her from injecting the IV drug. So the abscess was more from the injection.
Yeah, and I'm sure you know, lots of us on the call will recognise that giving ongoing anticoagulation in these patients is really challenging. In patients who are drug dependent, in terms of compliance with ongoing management and risk of future thromboses, even if they are provoked. There's a question on the chat asking, what was your decision for long-term management? So I presume that relates to long-term anticoagulation and whether this patient went on to have that.
So the plan for her was to continue on Clexin when she left hospital, because she had had rifampicin, and the advice from the hematologist was, because she's had rifampicin, she probably need about 4 to 6 weeks after stopping rifampicin to consider a change to DOAC. So the plan is for her to continue Clexin, and then she'll be followed up in the hematology clinic.
Okay, that's great. We'll just give it a couple more minutes to see if anybody else has any questions to put through on the chat. Just check the Q&A box as well. So we've got a couple of questions on the Q&A box about the nature of the bleed. Was it a hemoptysis or a GI bleed?
So it ended up being hemoptysis after we took a history. And then I think when she got stable, we ended up doing an OGD and there was no obvious source of bleeding. So it was agreed that it was hemoptysis.
Okay. That's great. Thank you very much. Very interesting and very nicely presented.